is Pukeology Podcast, where science meets your hilarious puke stories and the tips and tricks to stop that up chuckle that you need.
You never know what's going to spew out of her mouth. Here's
my mama,
Dr. Pukeology.
Happy birthday! Unless you know prior complications and health in your pregnancy are concerns, so you really don't know if you're going to be scheduled for a C-section or a regular vaginal delivery. Many of us don't even think about that or about C-sections being a part of our birth plan, but we really should, because of the fact that over 20% of births all around the world will actually end up in a C-section. So you are 1 in 5 pregnant women that could potentially be having the cut. Here's what you really need to know about a cesarean section in today's episode 28, C-section, Pregnancy Pukeology Podcast. Want no more morning sickness, pregnancy nausea, or how about no more headaches or migraines? Visit our sponsor, nomonausea.com, the only natural way to instantly stop your worst nausea, vomiting, or headaches now. Or just place Nomonausea Band on your baby registry for your delivery bag at Bye Bye Baby, or get it shipped in only 2 days for free as an Amazon Prime vendor on Amazon.com. And just know that they've always got your little ones taken care of with the first and only No More Nausea Kids and No More Sleepless Nights at your local CVS store, just in time for the travel holiday and your favorite Thanksgiving and Christmas carry-along. No more nausea, especially not in a car seat. You're going to hear some hilarious pregnancy humor that just may make you want to pee your pants. Like you don't have to pee all the time anyway, with hilarious stories like, I had a nice banana spew, a recent flight turned upside down, and last but not least, daddy catching puker. If you want to learn more about your pregnancy, humor and knowledge is the key to help you survive these 9 months. And just know we're in this together. 3 takeaways that you'll learn today is the science behind what is the real deal about a cesarean section, from why you might need one, a doctor's reason for being quick with the knife, ways to avoid a C-section, and helpful recovery tips, and most importantly, what a spinal anesthesia actually is and how is it going to give me the pain relief needed during the procedure. In today's episode 28, C-section.
The science of puke, Pukeology.
The U.S. has some of the highest C-section rates across the world. It is over 32% of all births. That means 1 out of every 3 will actually end up in a cesarean versus the national, or I should say international, global average of 20%. So guys, we keep climbing, meaning that the U.S. is leading when it comes to modern medicine, but at the same time, is it because of the fact that we're being quick to the knife? You'll find out. Before looking into why C-sections are more common in certain countries, let's take it back to basics and discuss what is a C-section. A C-section, also named Cesarean, spelled many different types of ways, was named after Julius Caesar, as he was alleged, if you could see me, I'm quoting right now, alleged to be born that way, and his mother lived for many years after this type of birth. Many suggest that he was not actually born this way because really there was only one documented case where a woman performed her own C-section and her baby survived. So the likelihood is very rare, but we'll just go with the story for right now. C-sections were carried out in ancient times in Rome only after the mother was declared dead during childbirth in order to get the baby out. Caesar's name, and in the Latin root word, actually means caedo, C-A-E-D-O, meaning to cut, cortar in Spanish, to cut. A C-section means to remove the baby via the lower pelvis abdominal area instead of the natural vaginal delivery in the vaginal canal. The most common indications are labor dystocia, meaning non-progressing labor, abnormal or non-reassuring fetal heart rate tracings, meaning the baby's heart rate is falling and it's not doing what it's supposed to be, fetal presentation, anything but head down for that baby during delivery, multiple gestations, more than one baby, and suspected fetal macrosomia, big baby, usually due in part to pregnancy gestational diabetes. I'm not trying to scare anyone, but a C-section is a major surgery. The overall global severe morbidity and mortality is 9.2% versus a vaginal delivery of 8.6%. When it comes to mortality and or mother's death, it is 0.9% in a vaginal delivery, and you're going through to a C-section, it's at 2.7%. I personally have had one of each, meaning that I had a vaginal with my first child, my son, and a C-section with my daughter, my second. And I would take a vaginal delivery any day of the week. The recovery for me was much, much quicker when I had a vaginal. And if I ever had a third child, I would 100% opt for a VBAC, a vaginal birth after cesarean section. If you want to learn more about what is a VBAC, check out Pregnancy Pukeology Podcast episode 21. It details everything, but the moral of the story is usually we women are told when we have a C-section, we have to have another C-section, but there are some OBGYNs who feel comfortable in performing a VBAC. So basically those muscles that have already been cut may be helping you to recognize that having a vaginal birth after that is still a viable option. The invention of modern anesthesia has allowed us to perform C-sections while keeping the mother alive and well. Starting with ether, which was a gaseous form of anesthetic by William T.G. Morton at Mass General, he used it to remove a facial tumor. Then the application became standard of care for childbirth of the very wealthy and the very affluent during the mid-1800s, especially after Queen Victoria made it popular having both of her children this way, utilizing ether. In today's day and age, we use one of three ways to properly administer anesthesia for childbirth. The most dangerous and considered the last resort is a full general anesthetic, where the pregnant woman goes completely off to sleep using a combination of IV drugs and anesthesia gases, because this is considered a true emergency C-section. Basically, when all else fails, this is what we have to do because we have to keep the mother safe and get that baby out as soon as possible. The second is very common, using an epidural that was already placed for a vaginal delivery. In case complications arise, what happens is a high dose of local anesthetic and sometimes a pain medication mixture is directly placed into that catheter, that very long string, after an epidural was placed for labor. The epidural space actually lies in front of the cerebral spinal fluid, meaning that you have to give a higher concentration, more of the drug, in order for some of it to seep through into the actual cerebral spinal fluid. That then creates this numbness effect so that the mother can comfortably have a C-section without having the pain. What does local anesthetics do? Numb the pain receptors. But you still will have touch, and you still will have a feeling of sensation, but again, not pain. You can still feel a little bit of pressure, and we'll talk about more of that in just a second. So you have to remember that this is not always 100% of a complete blockade when you use high volumes of concentration of drugs into the epidural space. And I say that because it is usually used for like non-emergent, urgent type of C-sections, where the anesthesia provider has enough time to check the level of blockade, but might not have enough time to perform a whole new spinal anesthetic. And then the other thing you have to consider is, remember, the cerebral spinal fluid, okay, whenever the actual medication is going from that epidural, into this little amount of clear fluid that you have that bathes the brain in the back, you don't want to overdo it, right? So an overdose of it can actually end up in a full general anesthetic because you've now blocked the muscles and or the motor response. And guess what your diaphragm is, where you breathe? It's a muscle. So that's why it's very important that you make sure to maintain to not eat anything within that period of time whenever you are actually contracting, because you never know if you have to have a full general anesthetic. And what's scary is that you don't want any of the food coming up into your lungs. Now, again, once the anesthesia provider assesses what is best, a spinal might be indicated, especially for scheduled C-sections. After looking at your entire health history, the anesthesia provider will actually position you like a mad cat and or a boiled shrimp with your back rounded facing them. So it's really important that you push your lower back out at them in order to be able to have a good range of motion. Now, there is certain people who have scoliosis and that could potentially affect. So if you were to feel any type of movement or like, ooh, a zing, please let the anesthesia provider know. I know whenever I'm placing different spinals, I always ask my patients, do you feel me on the right, to the left, or straight down the middle? After the back has been disinfected, so you're in this perfect mad, angry cat position, a small needle with local anesthetic numbs the area of the skin. Once that area is numb, then a small, longer needle, which is a lot thinner than the epidural needle, is actually placed inside of the back in order to be able to contact the cerebral spinal fluid. So it goes from the skin, it continues on, it goes past the epidural space and into the actual cerebral spinal fluid. That is what's called a spinal. This clear fluid will leak out a little bit, indicating that the anesthesia provider knows exactly where they're at, and then the concentration of high dose, a very small dose of high concentration local anesthetic will be administered directly into the CSF. Now, these women will be completely numb, usually from the very high point of the belly button, like above the belly button, all the way down to the feet. You will feel pressure and touch, but no pain. That's what local anesthetic does. It directly targets the pain receptors for a certain period of time. The complete feeling of your legs will return about 2 hours after recovery. And as a person who not only is actually providing anesthesia, but I've also been on the other side of the table, it feels like little minions are working on you. And all of a sudden, this big feeling of pressure, that just means that baby is coming out. All right, so once that spinal or epidural is placed and highly dosed, then the magic happens. The skin is cleaned. If it's a true emergency, we call it a splash and go. A bucket of betadine, which is an antiseptic, will literally be thrown onto the skin, and then the doctor's time starts the clock to get the baby out immediately. Our goal is to have the baby out in under a minute. If you're having a scheduled C-section, it's much calmer. The doctor can take their time cutting through each layer of skin, muscle, and the uterus. When you hear the suction, that suction noise and a lot of pressure, that's when you know that it's go time. Baby is here, and baby is literally being pushed out of that small incision that you have. Usually that is on a lateral basis, kind of like by your hip bones, but in the front of your abdomen. Now, if you do have a true emergency C-section and they're having difficulty, you could have a vertical up and down type, not just a horizontal one. And that's just because they're trying to get the baby out as best as possible. When you are hearing that suction, it's actually amniotic fluid that's being suctioned out. Because remember, the baby is in this nice little hot tub inside of the uterus itself. And the uterus is a muscle. So whenever you go and you actually are cutting through that, you have to remember that the baby is nicely, comfortably encapsulated to protect the baby. I saw the coolest, what's considered a gentle C-section. It's where the actual sac, The amniotic sac was actually kept intact, and you could see the baby, and the baby ended up breaking it itself. It was the coolest thing ever. Go on YouTube, check it out if you really are interested. I personally have never seen it happen that way. Usually it's a lot faster. Now, ladies, remember, even though that you have this beautiful baby, you hear the baby crying, screaming, you're so excited, even after the baby exits the room, and usually daddy does too, what ends up happening is you have to be sutured back up. There are many different layers. So if you're laying there on the table for another like 35 to 45 minutes and you're freaking out, don't freak out. There's nothing wrong. It's just they're trying to put all of your organs and everything back in there the way that they found it, close up the different layers to make sure that you don't have what's called adhesions. Now, again, adhesions are just kind of like internal scarring. Anytime that you've been cut, it happens. And I know a lot of you guys are going to hear the wonderful mystery of, hey, am I going to get a little tummy tuck with the second baby? Well, usually they try not to use the exact same line. And so again, if you do have a second C-section, a little minor piece of skin will be removed and then pulled down. Again, it's not a full-on tummy tuck. You have to have a lot more skin removed in order to make that smoother. But just wanted to bust a few myths while I was at it.
Growing up on a Tuesday? One puke story.
So I had a nice banana spew the other week when I decided to go on Google and look up C-section on YouTube. I saw this gigantic baby that was being pushed out of a small hole, and all of a sudden, my nanas that I had just ate started coming up. But then I saw a big blob of blood in it. Oh my gosh, in my panic, I made my husband come over and see it. So that was the look at my puke type spew. He soon looked at it and informed me that it looked suspiciously like one of the red grapes from the fruit bowl that I actually ate earlier. Oops, panic avoided. All I know is that I'm happy that I'm on the other side of the table just in case I have to have a C-section. Thank you, Jenny P2, for that hilarious puke story. On a recent flight to New York, I was only 11 weeks pregnant, and I, in the height of all-day sickness, have just been upgraded to first class, which was incredible. But nearing the end of the flight, when the seatbelt signs were on, I realized I feel horrible. Of course that would happen. I tried to hold it in, but miserably failed and ended up throwing up all of the amazing, luxurious food I had just eaten in one of those delightful puke bags, and then I had to hand it to an extremely glamorous hostess who looked absolutely horrified. Thank you, Hush Puppy, for that hilarious puke story. I literally was just thinking of your story when I was traveling, as there was a pregnant lady like next to me, and all I could do was I put a band on her, a no monage band, and was like, please just tell me that you're not going to puke up the guts, especially right here in front of me. All right. When I was breastfeeding my son, yes, you can still get pregnant again while breastfeeding. My milk used to come out super fast. My lovely son would throw up on me like quite frequently, and it was gross because it was milk and now solid foods. One day he was crying because the milk wasn't coming out fast enough, so he, inhaled it like he tried to, and so he started choking a little. So I turned him over in fear that the morning cereal was getting stuck, and he started puking everywhere. What he didn't realize is that it was all over my husband's lap. My husband started immediately vomiting because of the smell. I held it together until I was washing the laundry for the second time to get the puke smell out of his pants when I got a whiff and then boom, puked inside the washer. I can't tell you how many times I had to rinse it. Thank you, Samantha24, for that hilarious puke story.
Tips and tricks to stop the chuckle that you need.
So why do some women get C-sections and others don't? Let's go through the 5 most common reasons why, and then how to help you avoid it if possible. Number 1, labor dystocia. That meaning that the labor is not progressing. Your body's not doing that great of a job. Now, some of you guys will be added Pitocin so that your uterus will start contracting and really trying to, serve that baby its eviction notice. But when your water is actually broken, and by the way, ladies, if you are coming into the hospital because you are having a scheduled delivery, please ask them to put in the epidural before they decide to pop your water, right? You pop the water bag, it hurts like crazy. So it's so much nicer if you already are planning on having an epidural, just get it ahead of time before that they actually start doing it, because those contractions are gonna start booming out, ladies, just letting you know. So remember that once the water has broken, whether your water broke at home, whether they broke it right there in the hospital, the baby must be removed within 24 hours to avoid infection. So that's why they continuously monitor your temperature. They look at the baby's heart rate. Again, if there is a sign that there's infection, the babies naturally have a high heart rate. So like if you were to listen to the screen, right, your heart rate is like boom, boom, boom. And then the baby's is actually like do, 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 do. It's much higher. It's almost double. It actually is almost double yours. So that's why on the screen, whenever they're monitoring, you'll see 2 different heart rate fluctuations. One is for you and one is actually for baby. But going back, if they notice that there might be a possible infection, the baby's heart rate is going to start jumping up, which is actually the opposite. Usually we get concerned when the baby's heart rate goes down, but if the baby's heart rate is really, really high, it could signal, hey, listen, mom, there's some buggies that got in here and we need to take me out immediately. So in seeing that infection could potentially be creeping in, this is one of the indications, because your body is not expelling this baby in a short enough period of time. And we also get very concerned when any type of infection happens in any type of situation, because that's a long going. Now, antibiotics can be hung easily, but you just don't want extra complications whenever you go home. So let's start talking about the reality of it. Wonderful OBGYNs across the entire country are regular people too, right? Sometimes they've had a really bad night of call, they're up all the time, or they just want to go home. So this is what we call the witching hour. Most hospitals are on a 12-hour schedule, meaning that at 5 p.m., 2 hours before they're supposed to be going home, they start cutting women. And I say this, I'm not saying that every single one of the OBGYNs act this way, but in working as a clinician, as a physician for the last 10 years, I can tell you it really does happen in the labor and delivery floor. And it starts happening about 2 hours before that they want to go home. Why? Because a normal C-section is about an hour. You talk about suturing for another 30 minutes. They're actually out 30 minutes earlier than they normally would be. Be firm with your OBGYN and let them know that unless there's problems with the baby or in fear of my health and safety, I don't want a C-section. But if you're like some of the moms who's just like, honestly, I'm just tired of having this baby in, then maybe a C-section is something that you would consider and they would discuss. Number 2, abnormal or non-reassuring fetal heart rates. When the baby's heart rate starts acting funny, and when I mean funny is there should be a little variability up and down, because again, that signals that the baby is healthy and normal. What I'm talking about is when the heart rate goes down, also known as bradycardia. This is very bad because children, babies, kids are heart rate dependent, meaning that everything depends upon how fast their heart is beating. If you have an early deceleration, meaning the heart rate drops down before the start of the contraction, and the contraction is that big hill that you see whenever you start contracting on the tachometer that you will be placed. It's kind of like that gooey round circular thing that will be on 2 different sides of your abdomen, and you'll kind of have like a belly band that you wear over top of it. This is picking up your heart rate, the baby's heart rate, as well as the different contraction periods of time. Now, if it's an early deceleration, it means the baby's head is compressed. This is actually, hey, listen, we got problems. The baby's head maybe adjust, shift, but doesn't always end up in a C-section, but potentially could. Late decelerations signals that there's an impaired blood flow and oxygen to the actual placenta for oxygen exchange. Many times the mother will be repositioned. Sometimes you will see them completely flip on one side or the other, as the baby might like it that side or not, and oxygen can be administered. Then you have what's called variable decelerations. This is an indication of cord compression, and is actually the scariest, because imagine the lack of oxygen that the baby is receiving if the cord is continuously compressed, especially due to a vaginal delivery. Some babies, whenever they're born, you see them, their cord is wrapped around their neck multiple times. And if you can't get out the baby in a quick period of time, you literally are creating like a noose on the child. So you want to make sure that if that's the case, that maybe a C-section is the safest option. So fetal malpresentation. That just means the normal presentation, or the way the baby's head should be down. Now, if the baby is breeched, meaning that the feet are down, or frank breeched, where the butt is down and the baby's kind of in like this pike position, both of those are an indication for a C-section, because it can actually cause massive complication, shoulder dystocia, or my daughter, because she was frank breech, was identified as potentially having hip problems because, again, of the positioning and the way that the baby comes out. So when the baby is in this improper position, C-sections are considered the safest, most viable option. I personally did a bunch of handstands in the pool. I was trying to get my baby girl to flip. But again, you know how the story ends. I ended up having the knife. But there are medical alternatives called versions. So a version is done in the operating room at 37 weeks. The baby has to be considered full term, and full term is 36 weeks to 40 weeks. And you can have this version done where literally manually, by the way, it hurts, manually the baby is shifted to try to put the head back down where it belongs. If you have an anterior placenta, which can be seen on an ultrasound, you cannot have a version. The scariest thing that can happen to you as a mother is you could potentially bleed out. Don't even ask if you're having a version and you have an anterior placenta. They will tell you no. You know how I know? Because I had an anterior placenta myself. So again, a version is a viable option. Always remember, this could eventually end up in emergency C-section if there's something with the baby, if there's complications with the version. Multiple gestations. More than one baby, so twins and triplets. Some OBGYNs will actually insist that a woman with multiples gets a C-section because it's the most controlled form of delivery. Whereas, again, other physicians are very comfortable at attempting vaginal deliveries. If you want to know more about what to ask your doctor on your very first prenatal visit, check out episode 17, and you will get a whole list of questions that you need to ask your doctor just in case you hear 2 heartbeats versus 1. Fetal macrosomia. Those big old babies, those big babies, again, usually presented as gestational diabetes. Again, when the mother had diabetes prior, generally tends to have higher sugar content. So the baby is growing bigger and super large. Now, if you have a really big baby and a mother that has a very small pelvis, you can't fit that huge thing down a very small canal. So C-sections are indicated. These are the most common pregnancy physiologic reasons, but the mother's health is also to be taken into account. Maternal high blood pressure can present into what's called preeclampsia, eclampsia. And do you know what the only remedy for eclampsia and preeclampsia is? Take the baby out. Let me repeat that. The only indication or the only treatment for preeclampsia or eclampsia is remove the baby. Now, other types of maternal features like diabetes, cardiovascular instability, meaning that the mom's heart just might not be good. Mitral valve prolapse happens very frequently, and I always explain to patients, it's like when you have a door and then a door frame, right? The door is much more easier bowed than the actual frame itself. That's what happens sometimes when women are undergoing pregnancy. And then the last is renal insufficiency. What happens if you have other end-stage type dysfunctions with other organ systems? How is the stress of the baby during delivery going to affect it? And some doctors as well as midwives would recommend a scheduled C-section for those reasons. Remember that the no-nausea should be placed in your hospital bag because 80% of women will get sick, that is puking, during their actual C-section. Now, I know that some of you guys have seen No-Nausea Med Plus, which is used in over 90 hospital systems across the U.S. for labor and delivery suites, but it's better to be safe than sorry. So if your hospital doesn't carry it, then just go grab one from Bye Bye Baby, from CVS, from Amazon, from Walmart.com, or any of the other amazing places that actually carry it so that you can feel comfortable knowing that it is completely approved to go inside of the operating room. Some other helpful hints include after your C-section, take a full 6 weeks off and let your muscles heal. Use a belly band to keep pressure upon the wound, making sure that you change your dressings frequently because you don't want any type of infection after your C-section. Have a squirt bottle with nice warm water every time you go pee or poop. Yes, you will bleed out of your vagina even with a C-section. So have these big, pads that ready to go. Make sure that you take a stool softener and try to avoid narcotics post-operatively, so after the actual C-section. Ask instead for things like an ibuprofen on steroids, which we call Toradol. It has the same pain relieving factor as 7.5 milligrams of morphine without the terrible side effects like nausea, vomiting, itching, or constipation, because narcotics like Dilaudid or hydrocodone or oxycodone can back you up in the poo sector, and you already had your abdominal muscles cut. So help yourself out, ladies. Even if a C-section is not really on your birth plan, think of it. It's not the end of the world. Your muscles will bounce back. I can tell you that I still have a six-pack. Now it's inside the cooler a little bit, but I'm still able to perform the exact same physical regimen that I was prior to having a C-section. Now you know the science behind when you get a C-section, or when you might, why that is an actual possibility for some, and what type of anesthesia is to be expected. Because let's face it, the truth will set you free, ultimately giving you the answers for the best information about pregnancy that there is to date. If you love me, Dr. Pukeology, or Pregnancy Pukeology Podcast, let me know with a 5-star rating or hearts for like. Don't forget to download this episode, but more importantly, share it with all your prego friends. Thanks again for listening to Pukeology Podcast in Pregnancy, episode 28, C-section, what you need to know about a cesarean section.
Pukeology Podcast, edutainment at its finest.